Good morning to everybody, and thanks to the Egyptian Fertility Society for inviting me to give this lecture. Unfortunately, I cannot come to Cairo this year, but it's always a pleasure to exchange with you our last data. For 2020, my contribution will be on the pathogenesis of adenomyosis. This is a really intriguing disease. I have no conflict of interest. This is an intriguing disease because the history says that the first description was an adenomyoma, endometrial glands in the myometrium, in 1860 by Karl von Rokitansky, a German pathologist. So he was the first one to be described as pathologist. And then in the few years later, von Recklinghausen, again from Germany, visualized the adenomyomata from the posterior uterine artery wall. So the description of pathology of adenomyosis is really historical. But became a part of our textbook of pathology in 1972 when Charles Bird in the United States defined adenomyosis as a benign invasion of the endometrium into the myometrium, producing a diffusely enlarged uterus, which microscopically exhibit ectopic and non-neoplastic endometrial glands and stroma surrounded by hypertrophic and hyperplastic myometrium. So this is the definition of adenomyosis. In the same book of pathology, Robbins and Cotran, you can find that there is a diffuse form in which basal gland and stroma are diffused into the uterus, in the myometrium. Focal, you have one focal localization in the myometrium. Nodular, when you have a nodular architecture into the myometrium. So we have two different histotypes, two different phenotypes of the disease. And so this is the pathology. What was new in 2012? So very recently, the FIGO, the Federation International of Gynecology and Obstetrician, and Mac Monroe, he was the chair of the FIGO group on menstrual disorders, they published in Fertility and Sterility the new definition of abnormal uterine bleeding, and adenomyosis is considered, you see here, with polyp, adenomyosis, leiomyoma, malignancy, an anatomical cause of IUB. So finally, 8 years ago, we had a clinical definition as abnormal uterine bleeding of adenomyosis. Why we have adenomyosis? In this review on RBM Online in 2017 with Silvia Vannuccini, we published the 3 different pathogenetic mechanisms. You may have an invasion of the myometrium from the endometrium. You see here, this is the endometrium. So these cells can enter and interrupt the junctional zone, so you have an invasion of the myometrium. Second hypothesis, you have embryonic stem cell from the endometrium which become adenomyotic foci with a metaplastic mechanism, or you may have a retrograde in menstruation. They go to the pelvis and then there is an invasion from the outside. So if you see here, this is mechanism one by one. Adenomyosis, you have an invagination of the endometrium, you alter the junctional zone, and you have, and this mechanism may occur physiologically or because you have a tissue injury and repair. Leyendecker in Germany published this hypothesis that you may have, there is an invasion which is spontaneous or an invasion which is caused by surgery or by tissue and injury and repair. If you do an hysteroscopy, a curettage, you may facilitate pregnancy, you may facilitate TIR mechanism, tissue and injury repair. So these are 2 possible mechanisms. Invasion of the endometrium from the endometrium spontaneously or via mechanic. The second one is stem cell which are present in the endometrium. Embryonic or adult stem cell undergo metaplasia and de novo process. This is from Australia in Human Reproduction Update 2016. And then invasion from the outside, you may have Charles Chaperon and Garcia Solares, they published that probably focal adenomyosis may derive from the epithelial stromal cells, which goes in throughout the tube, and they implant into the myometrium from outside to inside. So it's a fascinating hypothesis, and they probably can be all true valid. We may have some adenomyosis from tissue and injury repair, we may have adenomyosis from spontaneous uterine contraction, from outside or from stromal cells. This is a nice picture which we recently summarized. Moving to the pathogenetic factors, these are the mechanisms. What are the factors which may influence the migration of endometrial cells into the myometrium? Steroid receptor, sex steroid receptor, proliferation and fibrosis of these cells into the myometrium, inflammation, and neuroangiogenesis. You see here, estrogens are studied. You can have allelic variant estrogen receptor alpha polymorphisms, which are associated with the risk of adenomyosis, estrogen receptor alpha and beta, more probably the alpha polymorphism. Or you may have a local estrogen production. You see here this publication, which say that in adenomyosis, you have an increase of aromatase, which stimulates the aromatization of androgens to estrogen. So local estrogen plus estrogen receptors. Again, you see here in this publication of 2011, high estrogen receptor beta expression in the myometrium of adenomyosis. These are the adenomyotic cells, the myometrium of adenomyosis. This is the control. You see how much more estrogen receptor beta expression. And regarding progesterone A and B, a progesterone B promoter is hypermethylated with concomitant downregulation of progesterone B, which is the most important, Sun Wei Guo published in 2010, and which has been confirmed recently in adenomyosis. There is a dominant state of PRA. This is by Beta Wei in Canada and Fertility Sterility 2013. So we have a situation which is very similar to endometriosis, in which you have hyper expression of estrogen receptors and lower expression of progesterone B and high expression of progesterone A receptor. And you see here again, progesterone I and B expression is reduced in adenomyosis. So the same as endometriosis. What about inflammation? We had some data on sex steroids. What about inflammation? Cytokines, interleukin beta, interleukin 10, TNF alpha, CRH, urocortin are increased in adenomyosis. Enzymes, which stimulates prostaglandin, COX-1, COX-2, metalloproteinesis 2 and 9, thrombin and proteases, they are increased. You see here, these are adenomyotic cells, COX-2, interleukin beta, urocortin, CRH receptor 2B are highly increased. These are data coming from our lab in Italy in Reproductive Science 2016. So high estrogen receptors, low progesterone receptor, high expression of inflammatory genes. Urocortin, you see here, may stimulate interleukin beta, which stimulates COX-2, prostaglandin, and you have symptoms. Two of the major symptoms of adenomyosis, dysmenorrhea and dyspareunia, derived from this cascade of events, from pro-inflammatory substances to COX-2 stimulation of prostaglandin synthetases. And so you have uterine contractility, dysmenorrhea, and dyspareunia. This is really very close, a clear explanation from pathogenesis to symptoms. Then you may have neuroangiogenesis. You see here, we published in collaboration also with this Dr. Wang in China, Taiwan, the autocrine and paracrine effect of VEGF, abnormal uterine bleeding. You have an increased microvascular density, and so you can explain why you have abnormal uterine bleeding, because you have more vascular endothelial growth factor. This is an important growth factor which increases vascularization, and you may have more blood bleeding. We repeated also with the NGF nerve growth factor and synaptophysin, and you have In adenomyosis, you see here very clear adenomyotic cells which express more nerve growth factors. So we have pain and vascularization. Growth factors and fibrosis, TGF-beta, follistatin, myostatin, activin A. You see here myostatin increased fibrosis, follistatin decreased fibrosis, and you see here we have an increased effect of myostatin and follistatin in these cells. And we define a profibrotic. Then by this publication, again from the lab of Sun Wei Guo in Shanghai, there is a publication in which the epithelial cells from the endometrium, you see here, they have a transition to mesenchymal cells, mesenchymal phenotype, and they have they cause smooth muscle metaplasia and fibrinogenesis. So the uterus of women with adenomyosis are estrogen dependent. They have a lack of progesterone receptors, more inflammatory cells, more vascular endothelial growth factor, more nerve growth factor, more growth factors which transform these cells in mesenchymal phenotype and fibrosis. So you see here hyperestrogenic state, progesterone receptor disruption, cytokines and growth factor, chronic inflammation, adenomyosis, endometriosis, they look very similar in this direction. Very, very similar. We have many similarities which are shared by these two these different diseases. And if you see the hyperestrogenic state, progesterone receptor alteration, inflammation, you have effect on fibrosis, pain, dysmenorrhea, dyspareunia, abnormal uterine bleeding, infertility. Don't forget, this is the meeting of the Infertility Society, and you are aware that women with adenomyosis have 3 times more miscarriage. So you may become pregnant, but the uterus is not good for keeping the embryo implantation. So you have early pregnancy miscarriage, very, very common in these women. So when you have dysmenorrhea, abnormal uterine bleeding, and miscarriage, you have to reflect and think, is this a possible situation of adenomyosis? And then you will have, in the next presentation by Professor Yutaka Osuga and Jacques Donnet, you will listen about the possible challenge, and particularly also Shafki Badawi will explain you more about infertility. But the link between adenomyosis and endometriosis is very close in this mechanism of action. This is a nice slide which summarize the possible pathogenetic mechanism and symptoms. You see here the symptoms are pain, heavy menstrual bleeding, and infertility. These may be caused by angiogenesis, inflammation, neurogenesis, and fibrosis. So the uterus, which is apparently a good endometrium, however, part of this endometrium, because the hyperestrogenism, the progesterone resistance, cause abnormal uterine contractility, and you have and it is possible that the uterus is not absolutely prepared to have an embryo implantation and to have a pregnancy. And you have abnormal uterine contractility, oxytocin and prolactin are also supposed to be part of this mechanism, which cause the hypercontractility of this uterus. So women with adenomyosis, which is much more common than what we usually do in our clinic, should be taken into differential diagnosis with endometriosis, with uterine fibroids, because many times women with adenomyosis have also endometriosis or uterine fibroids. And they get, when they summarize, you have adenomyosis plus fibroids plus endometriosis, the infertility is really very high, and you have many difficulties, even though when you do assisted reproductive technology. So before to do ART, assisted reproductive technology, do a very good diagnosis for adenomyosis, because this could be a very good surprise for many of you doctors, and you may prepare much better the uterus for the embryo implantation. I finished suggesting to you to become member of the Society of Endometriosis and Uterine Disorders, SEUD. It's very simple to become member because you can join Gamal Serur. Professor Gamal Serur in Cairo is one of the members of the board. And you can join if you go to our website. You will become member very simply, putting your registration form, and you will have the Congress next year. We hope to have finally a live Congress in Stockholm in May, and we hope you will be the Egyptian representative will be very high like in the past. So we really are very proud to have Professor Serur, but also many Egyptian friends and colleagues who wish to become member of our Serur Society. Thank you for the attention.